The following podcast is part of a certified educational activity titled Securing Equity in Care and Outcomes for Older Patients with HR-positive HER2 negative MBC, leveraging patient assessment, clinical evidence, real-world experience, and shared decision-making to individualized care. Access the entire activity and complete the post-test at peerview.com/ZWD860. Downloadable slides and practice aids are also available.
Hello, and welcome to Securing Equity in Care and Outcomes for Older Patients with HR positive, HER2 negative, metastatic breast cancer. Here, we're focusing on leveraging patient assessment, clinical evidence, real world experience, and shared decision making to individualize care. I'm Hope Rugo, a professor of medicine at the University of California, San Francisco's Comprehensive Cancer Center, where I specialize in breast cancer. I'm joined by my colleague, Rachel Friedman. Rachel, tell us about yourself.
Hello, I'm Rachel Friedman. I'm a medical oncologist in our breast oncology program at Dana-Farber Cancer Institute, associate professor of medicine at Harvard Medical School, and I'm the founding director of our older adult program for patients with breast cancer. Great to be here.
And I'm also joined by senior nurse practitioner in our program at the University of California, Sarah Donahue. Sarah, introduce yourself.
Hi, I'm Sarah Donahue. I'm a nurse practitioner. I work in the breast care center at UCSF along with Dr. Rugo. Thank you for having me.
Great, and welcome. All the two of you to our discussion today. We'll be doing a few different areas. Our goals are listed here, and our focus I'll show you in just the next slide. So we'd like to equip you with knowledge about clinical and real-world evidence on CDK4/6 inhibitors as first-line treatment for older patients with HR-positive, HER2-negative MBC, and enhance your awareness of the geriatric domains and assessment tools that are relevant to us as clinicians to obtain a comprehensive health status evaluation of older adults with breast cancer who make up a large portion of our patient population. We also would like to improve your skills in how to formulate a personalized treatment plan for older patients that includes CDK4/6 inhibitors and enhance your ability to address the practical challenges that are associated with CDK4/6 inhibitors in clinical practice when we treat older patients, including our treatment selection, dosing, potential drug-drug interactions, and adverse event management. This shows you our agenda for today. We'll start with an introductory module talking about closing the gaps with geriatric care by Rachel Friedman. Then I'll review with you in Module 1 our efficacy focus, looking at older patients, but also reviewing some of the more recent real world evidence on CDK4/6 inhibitors. In our second module, Sarah Donahue will talk about a safety focus and how we can make safety informed decisions using evidence in older patients. In Module 3, Rachel Friedman will go over some of the tools that we have for geriatric screening and assessment, how to evaluate fitness in older patients and apply these to clinical practice. And then we'll talk about those tools in assessing a real patient who's receiving CDK4/6 inhibitors as first line therapy for metastatic HR positive, HER2 negative disease, and see how that patient's been doing and how we might use these tools to apply them to decision making in clinical practice. We'll go on now to our introductory module, and I'll turn over the podium to Dr. Friedman.
So, this will just discuss some of the background in this discussion, looking at real world challenges and opportunities for improvement of geriatric care in the setting of hormone receptor positive, HER2 negative metastatic breast cancer. Just to give us some context, this subtype of breast cancer is the most common subtype in patients age 65 and older, and the incidence increases with age. Older patients with breast cancer have more comorbidities than younger patients, and their breast cancer outcomes are worse than their younger counterparts, including when they have metastatic disease. There's potential for drug-drug interactions and also a concern for polypharmacy because of the many medications some of our older adults take. And we have to think about functional capacity, cognition, and social psychological factors which can affect our treatment decisions in the older adult. And increasingly, functional age is recognized as being a more descriptive way to talk about somebody's age than their true chronological age when evaluating their health status. Therefore, the treatment and management of older adults with breast cancer requires particular attention to the balance between efficacy, safety, quality of life, and patient preferences and priorities. But because of these concerns, older patients with breast cancer often may not receive appropriate treatment. And in particular, patients 75 and older often receive less aggressive treatment and have poorer survival rates. And so, as we look to the evidence today, it's important to acknowledge that our prospective evidence is limited in the older adult with breast cancer. Few trials have successfully enrolled patients 70 and older in the large phase 3 setting. Secondary analyses of enrolled trials are very helpful, and you'll hear about them today, but they are often underpowered, potentially ad hoc, and sometimes fraught with limitations. Trials also tend to enroll the healthiest of our older adults, which is not always representative of those we see in practice. And I think that that can be complemented nicely by some of the real world data you'll hear today. And the data collected on these clinical trials often don't inform us on comorbidity or functional status of patients who are participating in them. Again, real world data can be very helpful, but there are, of course, inherent biases that we can't escape, which we'll discuss today. And increasingly, trials are being designed specifically for this population, and there's a national effort to enroll a more diverse population of patients with regard to many factors such as race, ethnicity, and age. And with that, I will hand it back to you, Hope, for Module 1 on efficacy.
Thanks very much, Rachel. That was really a very interesting start to our program today. And we're now going to talk about clinical trial and real world evidence on CDK4/6 inhibitor use in our older patients with HR positive, HER2 negative disease. And we'll keep referring to them as HR positive since we know they're going to be not classically HER2 positive. So, why are we looking at both clinical trials and real world observational studies? These are very complementary and they've become increasingly important as we've had a number of different drugs that seem very effective and target the same area in terms of treatment. And, for example, CDK4/6 inhibitors. We had this in the past as well, but we really didn't have the tools to do real world studies. Now we do due to a variety of both insurance and other databases like Flatiron. So randomized trials, as have a specific patient population, strict eligibility and exclusion. There are pre-specified protocol-defined endpoints that are uniformly assessed, and you randomize patients to treatment or a comparator. Also, of course, as you know, this is highly monitored, controlled, and because of this, you may not really be seeing the patient population we treat in real life because of the strict eligibility and exclusion criteria. And we all know this in clinical practice. There are patients who just never will go on a trial, won't seek a trial, or aren't eligible to go on a trial for a number of different reasons. And even just distance from a site that does trials can be an impact. In contrast, real world observational studies look at the real world group. So they don't say why you gave something or not, but you can tell one population that got treatment with a specific treatment approach and another that did not. And you can compare the outcomes there. You can also look at patient reported outcomes, such as quality of life, if you've collected that information, and adherence to therapy. You're not randomizing patients and there can be bias. And so there are several statistical uh, plans and calculations that allow you to correct for this bias and are accepted internationally by our statistical and regulatory communities. So it turns out that in the current era where we're doing these big phase 3 trials, and in addition to not maybe being the patients that we treat in practice most commonly, we also are seeing change in standard of care that's occurring rapidly while we're doing a trial. So the trial completes accrual, and before you've even presented the data, there's been another drug approved in that setting. So that can also make a difference while real world data is really important. First, I just want to talk to you about a recent real world study that was just published in ESMO Open, and we presented at San Antonio. And this was trying to address a complex question, which is that the phase 3 first line trials looking at the three CDK4/6 inhibitors plus aromatase inhibitors were all done at different times sequentially because palbociclib was the first approved drug. And then it took 2 more years to approve the other two, and they were approved sequentially even in the same year, ribociclib first and abemaciclib second, with palbociclib being the first approved CDK4/6 inhibitor. So treatment was changing. The ability to sequence treatment, essentially cross over to a drug, even if you were enrolled in a trial and were on the placebo arm, what grew over time, and the so that patients who were on the first trial were more likely to have received a one of the other CDK4/6 inhibitors over time, and the restrictions were greater as we started the trials than as we went through and understood that there weren't cumulative toxicities and how to really understand which patients should be treated in these trials. So things changed over time is the bottom line. We'll never have a head-to-head clinical trial looking at the different agents. So what we did was go back into the Flatiron database to try and understand whether or not we could see any differences between the three different CDK4/6 inhibitors combined with aromatase inhibitors. We had done previous real-world studies looking at palbociclib and an aromatase inhibitor, both progression-free and overall survival, but in this situation, we wanted to look at all three. And because the progression free survival in the first line trials had essentially the same hazard ratios across all three trials, but overall survival that was statistically significant was only seen in the ribociclib phase 3 trial in the first line setting. We looked at overall survival as our first endpoint and are now looking at PFS as a second report in the future. So, what we did in the database was to look at all eligible patients with HR positive disease who used a CDK4/6 inhibitor plus an AI between February of 2015 and November of 2023. And then the end of the analysis was May of 2024, our data cutoff. And it's important to keep in mind that the Flatiron database is only provides data from the US nationwide, although it's expanding to other countries now. So, overall survival was the number of months from start of the treatment to death, of course. And we looked at median and landmark rates as well as confidence intervals for OS with Kaplan Meier. And then we had methods for comparative analysis, of course, unadjusted first. We then looked at SIPTW, which is a standard method of adjusting for the potential bias in real world studies. We did a multivariable Cox proportional hazard model, which is a sensitivity analysis. And then we did a second sensitivity analysis, which is one-to-one exact matching. It's actually important because we did a sensitivity analysis that started in 2017, which is when ribociclib and abemaciclib were approved. And then we did a second sensitivity analysis looking at the date from when abemaciclib was approved because it was the last approved drug. We also looked at a number of different factors in the propensity score that are listed at the bottom of this slide. You can see there were 9,146 patients. Most received palbociclib because of the approval date, 6,800, almost 1,300 ribociclib, and a little over 1,000 for abemaciclib. And here you can see the results with overall survival, which was essentially identical between the three different groups of patients. And we looked also at various time points at OS rates, and you can see the 12, 24, and 30-month rates here, which is really helpful. On the left is the unadjusted analysis. On the right is after SIPTW. So, really important. And I think this data suggests that there's no significant overall survival differences between these drugs when you look at what's happening in a real world population. Here's the data from our sensitivity analyses looking at 2017 as a start date and one-to-one exact matching as well. And you can see the hazard ratios remain essentially at 1. So, how do we put this into the context of clinical trial data? This shows you the different trials that are available in the first line setting. It's important to keep in mind that Mona Lisa 7, that looked at ribociclib, is the only first line trial that focused on patients who were pre and perimenopausal who also received ovarian function suppression. A really important study because this showed that one, we shouldn't exclude those patients from first line trials anymore. And two, that there was significant efficacy, very similar to what we saw in the postmenopausal patients using ribociclib in combination with an AI or tamoxifen. and ovarian function suppression, although there was more QT prolongation with tamoxifen, which isn't generally recommended. The data from P-Verify is stuck on the right-hand side, which I think is really interesting. The overall survival data looks a little more similar to what we saw with the Paloma 2 trial, and a little bit shorter than some of the other trials. Pretty dead on for Monarch 3. But I think that you can see that the OS data is quite similar. There's just no statistically significant difference here when you combine them. If you look at the hazard ratios for the PFS, you can see that they all line up to be identical. So we never really could figure out why it was if you had similar PFS, you'd have a difference in OS. So I think this is really helpful information. So, what randomized clinical trial and real world evidence exists in older patients in terms of efficacy of the CDK4/6 inhibitors? So here's the Paloma trials. Paloma 1 was the first phase 2 trial looking at palbociclib versus with letrozole versus letrozole in patients in the first line setting, 165 patients. Then there was phase 3, Paloma 2 and Paloma 3, looking respectively at the first and then second or greater line. One of the things about Paloma 3, which is different from the other later line studies, is that it was later line. You could have received you could have progressed on adjuvant endocrine therapy or after metastatic treatment, but you could have received 2 prior lines of endocrine therapy and up to 1 line of chemo, and about 30% of patients had received 1 line of chemotherapy. So it's a little bit different from the other trials, which excluded chemotherapy. And you can see, 666, 521 patients. So what about in our older patients? Here's the patients who are 65 years or older looking at progression-free survival. Here's the intent to treat analysis, and then the smaller number of patients who are 65 years or older. And you can see that the hazard ratios are almost identical at 0.6, which is certainly very encouraging. Median overall survival was not statistically significant, as I mentioned earlier, in Paloma 2 in the first line setting. In the older patients, you can see numerically there's a bigger difference. We really have no idea why the data is like this given the PFS benefit, but you can see that certainly there's no detriment in the older patients. What about in the second or greater line setting? Here you can also see the intent to treat on the top, and then the age 65 to 74 and 75 or older. We're retaining the PFS benefit with very similar hazard ratios. The numbers are just the hazard ratio 0.27 just has to do with small numbers in the 65 to 74-year-old patient population. And then when we looked at overall survival, you can also see that this was the not statistically significant with a p-value 0.09 in intent to treat. When we eliminated the patients who'd had chemotherapy, it actually had a similar hazard ratio to the other 2 trials that showed significance and nominal because it was a subset analysis that wasn't planned and nominally statistically significant p-value. What about in the patients who are 65 or older? My guess is, although the numbers are small, so we couldn't really look at this, my guess is that these are the patients who are less likely to have received chemo first, because that was before our current data, and even now in many countries has been a standard approach to younger patients with the idea that they would have better outcome. Although lots of contemporary randomized trials have shown that that's not the case at all. In fact, outcome is better if you start with endocrine therapy and a CDK4/6 inhibitor in younger patients, even if they have but visceral dominant disease. But in this analysis, in the age 65 or older, the hazard ratio is 0.52 and the confidence intervals did not cross 1. So really encouraging in this patient population. What about Monarch 2 and Monarch 3 that looked at abemaciclib? And here you can see that the patients who are 65 to 74 and 75 or older also had improvement in progression-free survival in the first line setting as well as in the second or greater line setting. The Monarch trials are funny because they're reverse order, right? So Monarch 2 is the second line, Monarch 3 is the first line. But you can see that the curves separate here and the hazard ratios are quite nice, although Monarch 3 was a smaller trial, so the numbers in the older population are really small. And so the confidence intervals all overlap as they did in the final overall survival analysis and the intent to treat. What about ribociclib in older patients? Here's across the Mona Lisa trials. I mentioned that 7, of course, won't help you much because that was defined as premenopausal. And I don't think we're finding anybody who's 65 or older is premenopausal. But here you can see when they pooled the analysis, and looked at patients who were less than 65, 65 to 75, under 75, 74, and then 75 or older. You can see the PFS benefit is maintained. The hazard ratios are very similar, really great, almost at 0.55 across the entire group. Very encouraging. And when we looked at overall survival, again, the numbers get to be quite small. So the confidence intervals overlap one, but certainly it does appear numerically to be improved in patients who are older. The FDA did a pooled analysis to look at efficacy in patients who were 75 and older. So, quite an older group of patients, and they had a lot more patients because they were able to pool all the different trials. And here they showed that the efficacy was very similar in the older patients who received CDK4/6 inhibitors with their endocrine therapy, which in this case was first line, so an AI, versus those who received the AI alone. Which was really encouraging. And we'll hear more about the toxicity in this analysis a little bit later. There are some real world databases looking at older patients. So here's palbociclib letrozole versus letrozole alone in the same Flatiron database, looking at patients who are 65 years or older that we published in 2023, 796 patients, and basically looking at patients where investigators decided to give the combination versus letrozole alone. And you can see it's a fairly robust number of patients, so almost 800 overall. And our endpoints were real world PFS and overall survival, as well as tumor response. So here you can see the unadjusted and adjusted real world PFS. Again, we use this IPTW, which is a standard statistical adjustment model for real world analyses. In the older patients, you can see that the difference in PFS went from 15.8 to 22 months, almost identical to the unadjusted analysis, really encouraging data. And then looking at the overall survival, we also saw very similar information where we looked at the median overall survival not reached for palbo and letrozole versus 43.4 for the letrozole, very similar to other databases after IPTW. In addition, there was a published in 2023 a SEER Medicare database in patients that were 65 years or older. Here, they were trying to compare the survival outcome with a diagnosis of de novo HR positive, HER2 negative metastatic disease. So, this was a retrospective analysis. Again, de novo disease, so no prior treatment and no prior diagnosis, diagnosed between 2015 to 2017 with follow up in 2019, and they could only have received Palbo because the other drugs weren't approved. And they had to have also started treatment within 12 months of diagnosis. And their primary endpoint here was overall survival with landmark analyses. So here's the unadjusted overall survival in these patients who are 65 years or older, showing that you hadn't reached the median overall survival versus 34.8 months of endocrine therapy alone, a little bit shorter in this older population with endocrine therapy alone than in the overall real world databases. And the duration of follow from treatment initiation was at least 2 years. Many more patients with events in the endocrine therapy alone versus the CDK4/6 inhibitor arm. And then Palomage is a trial that was recently updated at San Antonio 2024, looking at women who were 70 years or older. And this was actually a prospective study done in France where patients were followed, so they didn't intervene. 816 patients who were 70 years or older, and those who had initiated palbociclib without a prior CDK4/6 inhibitor between 2018 and 2020. They had two cohorts, so endocrine sensitive first line treatment, and then the cohort B was endocrine resistant and later line treatment. Again, there's a lot of discussion about when you should give a CDK4/6 inhibitor in older patients. So the primary outcome was discontinuation of palbociclib by 18 months, a year and a half. Secondary outcomes are listed on the slide, but also included looking at toxicity, but geriatrics analysis called GA using a standard tool, the G8 screening tool that we'll learn more about a little bit later in this program. And then they looked at time to treatment failure. And here you can see the time to treatment failure was 23 months. The real world progression free survival was 30.4 months, and 164 patients had experienced disease progression or death by this follow up time point. But 94% of patients were alive, and 39% were continuing palbociclib treatment. So I think it's a very interesting data set that showed similar effectiveness in the older patients compared to younger patients, even in a prospective study started almost a decade ago. And then they looked at the geriatric evaluation score, and you can see that if they had the score, so 209 patients had a lower score, and they looked at a person who was able to provide care and support, and most patients did have that. That was their reference. If you looked at the multivariate analysis, if you had a poor geriatric evaluation threshold, you had a higher risk of treatment failure. This was also true for patients who lacked a caregiver or support. So these are really important things to discuss with patients and also to follow over time. Really important in order to maximize the benefit and efficacy of treatment as well as minimize toxicity in our patients. So, both frailty and social support are really important. So, here's the time to treatment failure by geriatric status. So, here's the normal G8 score, and here's the altered G8 score, so a lower score. And they looked at the different doses that patients received, and they saw a higher discontinuation rate at 18 months and a shorter time to treatment failure, as I mentioned earlier, a shorter median real world progression free survival in patients who received this reduced dose at initiation. It didn't reach statistical significance, but it's really interesting. So look at the altered G8 score where they got 125 or 100 versus 75. It's just a little better. The normal G8 score, the patients who received 125 milligrams to a little bit better overall. It's hard to see in the curves, but you can see in the numbers below versus those who had a normal G8 score. So it's an interesting thing. I think that for patients who are doing well, that's it sort of highlights what we're going to talk about in a little bit more detail shortly. Is that if you are in good shape and older, you should start at full dose because you're going to get the maximum benefit. If you're having a more frailty based on a scoring system, it may be that starting at a lower dose would be better, because you have a higher discontinuation rate and a shorter time to treatment failure. So we really want to try and maximize our ability to support these patients as well as an efficacy, as I mentioned earlier. So let's just before we go into the next module and talk about safety, let's just briefly talk about a little bit about some of what I've talked about. Rachel, how do you use real world data in your clinical practice, and do you?
I mean, I think everything you showed is so reassuring, right? You showed the clinical trial data and whatever we can say on pooled analyses and trying to really focus in on this population. But that real world data is what we're seeing in practice, right? Those are real patients who are not, especially in this age group, represented on studies. And yes, there are biases. I think primarily the one to focus on for the older adult is the treatment decision. Like you said, you don't have information on that. And so there is some bias that perhaps a person not receiving a CDK4/6 inhibitor is somebody who may be more frail at the get go and may be destined to do worse overall. But I think what you showed is pretty powerful. And I think that we can pretty much say with a lot of certainty, given that breadth of data in both real world and clinical trial settings, that older patients derive the same efficacy as younger patients. And I think it's important to consider the other factors, their morbidity, and like you mentioned, the G8 scores and thinking about dosing. But I think we can feel pretty comfortable that these are safe drugs to use.
Absolutely, and that's really important. And then, Sarah, do you generally, and we'll talk about this more, of course, as we go forward, but do you use age and frailty in order to decide what dose you're starting with CDK4/6 inhibitors?
I definitely think about that. I also think about which CDK4/6 inhibitor. But just as far as dosing goes, thinking about a lower dose for your more frail patient, for sure would think about that. You can always go up on the dose if they do well in the first cycle or two. So just having that option there, starting lower is always a great option. The other thing that I think about is that continuous dosing of abemaciclib as compared to the intermittent dosing with the palbociclib and ribociclib. If I have a patient that has less support at home, maybe I would think about that um, as a possibility.
Really interesting. So let's go on, given that sort of start, and I'll turn over the podium to you, Sarah, to talk about safety and making safety informed decisions. What can we learn from the trials that have been presented in geriatric patients?
So thank you so much, Dr. Rugo. Yes, let's get right into that. So first, I'm going to start with going over the most common side effects of the different CDK4/6 inhibitors and how they're different between them. Palbociclib, most common is neutropenia. There is some diarrhea and some less common increases in the transaminases. With ribociclib, similar neutropenia as palbociclib, similar diarrhea, but more issues with increases in the transaminases. And then there's also risk of QTC prolongation. With abemaciclib, it's a little bit more different than the other two medications in that neutropenia is less common, diarrhea is more common. Uh, Increases in transaminases also occurs like ribociclib, and then you have this small risk of thromboembolic events. Because of the lower risk of neutropenia, it's dosed continuously, 150 milligrams twice daily is the starting dose, whereas palbociclib and ribociclib, they are dosed 3 weeks on, 1 week off, with labs after that 1 week off to make sure the neutrophils are okay and you can continue on. There are the dosing levels listed here as you reduce doses. So the main toxicities, again, are exhibited here, where you see that there's more neutropenia with palbociclib and ribociclib, and more diarrhea with abemaciclib. The fatigue and nausea were similar across the groups, maybe a little bit more fatigue with abemaciclib. Here, just bringing up that pooled analysis. So this is looking at all three CDK4/6 inhibitors and the safety from the pooled analysis. And it showed that in general, the grade 1 and 2 adverse events were similar in the older patients compared to the younger patients. Here you can see they used a cutoff of 70 years old or 75 years old. Uh, for the comparison. The grade 3 and 4 events were a little bit higher in your older patients. Grade 5 events did occur in this analysis and a little bit higher in your older patients as well, but still a low percentage overall. Adverse events leading to dose reductions or interruptions were a little bit higher in your older patients, 70%, for example, in your younger patients, dose reducing versus 80% in your older patients. So, still quite common to have a dose reduction, but a little bit higher in your older patients. Adverse events leading to discontinuation of the CDK4/6 inhibitor altogether was higher in your older patients. Hepatotoxicities and serious adverse events were more likely in your older patients. For example, 8% hepatotoxicity that was grade 3 to 4 in your older patient compared to a 5 or 6% in your younger patient. Fatigue was a little higher in the older patients, grade 3 fatigue, diarrhea higher, and grade 3 diarrhea was a little bit higher. But overall, the differences were not that large between the groups. There was just a trend towards more of these toxicities in the older populations of patients. So here I'm going to focus on palbociclib for the next few slides. In this pooled analysis from the Paloma trials, you can see in the solid bars, the patients that were on CDK4/6 inhibitor on palbociclib with their endocrine therapy. And if you focus on those solid bars, you can see that the side effects that are most associated with palbociclib were, of course, higher in those patients that were taking the palbociclib. And it was for marrow suppression like neutropenia, thrombocytopenia, and anemia. You can see it's a little bit more so in your patients that were older than 75 compared to the younger patients. But things like diarrhea, hot flashes, nausea were pretty similar. There might have been a little bit less nausea with your older patients. Um, they did see that as far as febrile neutropenia goes, there was slightly more increased risk of having that with your older patients, but it was still a low risk altogether at 2.4%. And the discontinuation rates across the subgroups was higher in your older patients, but still a small percentage at 6% compared to 1.6% in your younger patients. Here again is similar information, just looking at the patients that discontinued the palbociclib. Most of it was because of disease progression, death, patient choice, but there were about 20% of patients that discontinued because of toxicity. And those toxicities, again, are listed here, similar to the prior slide, with neutropenia being the leading cause, followed by fatigue and anemia and thrombocytopenia. Less common interstitial lung disease and CBA. So now looking at the Alliance trial, a different trial, you can see that patients on palbociclib that were older, so here they're separating out by your 70 to 74-year-old patients versus your older than 75-year-old patients, that neutropenia was similar among the groups. Anemia might have been a little bit higher in your older population, maybe a little less leukopenia, but generally similar hematologic toxicities with these patients in this trial. Fatigue was similar across the groups, diarrhea, maybe a little less nausea, oddly more neuropathy, even though we don't commonly think of that as a side effect of a CDK4/6 inhibitor. There was a little bit more anorexia or decreased appetite. Mucositis was similar. Infections were similar, and thromboembolic events were similar. Also in this trial, they tried to figure out if there were certain risk factors that patients had for developing toxicities, and really none of them actually had statistically significant p-values. One of them, BMI, listed here, showed a possible trend towards significance with the obese group, as you can see bolded here, experiencing less risk for toxicity. The thought behind that could be that palbociclib is a fixed dose. It's not based on weight. None of these medications, CDK4/6 inhibitors, are based on weight. And so perhaps those patients that are heavier are experiencing less of the pharmacologic effect of the drug, and therefore less of things like neutropenia and diarrhea from the medications. In this trial, they looked at dose interruptions, dose reductions, early discontinuations, and hospitalizations, and they found that pretty much throughout, the older patients greater than 75 years old were experiencing more of that compared to the younger patients. So switching over to ribociclib, you can see here that they, in this analysis, they're looking at all of the Mona Lisa trials 2, 3, and 7, and it shows that the older patients experienced actually a little bit less neutropenia than the younger patients. Febrile neutropenia was slightly more common. Infections were similar. Liver test abnormalities were similar. QT prolongation was a little bit more, and same with ILD or interstitial lung disease. Just thinking about why they could have seen the less neutropenia, it could be perhaps that those patients were started on a lower dose level. I'm not sure what dose they were on, because the starting dose is 600, but they could have been on 400. Here we're looking at the percentage of patients that had a dose reduction or discontinuation. What they showed is that the older patients had similar rates of dose reductions, but they had higher rates of discontinuation. And of the patients that discontinued, about 50% of those patients discontinued without trying a lower dose level first. The most common reason for a dose reduction or discontinuation was elevated liver enzymes, so that could explain that. And then finally switching over to abemaciclib, in the Monarch 2 and Monarch 3 trials, they looked at, they pooled all that data and they looked at rates of side effects with patients 75 and older compared to the younger patients. And there was similar rates of any grade diarrhea, although grade 3 and 2 and 3 diarrhea was more common in your older patients. Neutropenia was actually less common in your older patients. Again, I don't know if that's a dose that maybe they were put on with that was lower. Liver test abnormalities was actually less in your older patients. And uh, Venous thromboembolic events was a little bit higher. ILD was about the same. So there's an upcoming trial, a phase 2 trial, looking at abemaciclib and endocrine therapy in patients over 70, for patients that have already been on a CDK4/6 inhibitor. So this is second line. And I'd like Rachel, can you comment on this? Because I think it's your study.
Sure. Yeah, I'm a co-investigator on this study. This is being led by a team at City of Hope, and it's ongoing and enrolling. And this is really trying to expand upon the prospective evidence that we have in this population, given some of the limitations in, interpreting safety data in these pooled analyses like you just described. And this is really trying to follow the Alliance trial that you mentioned, which is also prospective and trying to gain more toxicity information in the older adults specifically. And so this trial is designed for those 70 and older only. And it is a very pragmatic study. It's enrolling patients who have hormone receptor positive HER2 negative breast cancer who have had prior CDK4/6 inhibition in the metastatic setting, or in the adjuvant setting very close to the time of their recurrence. And the provider can choose the hormonal therapy partner for that abemaciclib, and patients are treated as per standard care, with the primary objective to look at grade 3 toxicity and to really gain information about that. There's a lot of rich correlatives on this study, which focus on geriatric assessment elements and other functional markers. And I think it's going to be really interesting to get these data in the coming years. With that, we'll be transitioning into module 3, which is thinking about some of the tools that we use in the setting of the older adult with breast cancer, understanding the patient and informing care, our tools for geriatric screening and assessment to evaluate fitness of the older adult. So, one thing to keep in mind, of course, is that, as I mentioned before, age is often best described by one's function. You can see these two patients are the same age, but they are very different in their health status, with the left person being incredibly fit, of course, and the right being in a wheelchair and having more functional impairment, and perhaps maybe closely aligned to the patients who we see in practice in this age group. So the geriatric assessment was developed by Dr. Arthi Huria to really try to tease out how we can assess this functional age. And she took a battery of surveys that were used in the geriatric setting and truncated them for the oncology setting, trying to really limit what we asked patients, but also gaining rich information about where they're at. And so this geriatric assessment assesses functional status, comorbidity, medications, cognition, psychological status, nutrition, social functioning, and social support. And it is a survey that patients take with all of these elements included. And then there are 3 small provider components, which are highlighted in red, including the Karnofsky performance status, a timed up and go test, and a cognitive screen with the blessed orientation memory concentration test. All of these tests have been put together. The clinical tests don't have to be done by a clinician. Clinic coordinators and practice assistants and many other staff can be trained in this. It's very easy. And it really gives you a rich assessment of that person's overall function and health. And the benefits of using that geriatric assessment have been shown over and over again now in the literature. This information uncovers problems that weren't detected by our traditional history and physicals that we do in our practices. Having this information has been shown to be able to predict hospitalizations, survival. It's been shown to be feasible in practice. It can help clinicians with decision making and impact care plans. It can help the teams mitigate toxicity, which is a lot of what you've been hearing about. The toxicity that we see in these patients. This helps personalize referrals, improve communication, and has been shown to not have a detrimental effect on survival. There has been concern that if you gain this information and do upfront dose modification or make changes, that you might actually have a negative impact. And studies have actually shown that that is not the case. And so there are a lot of benefits to incorporating this. And some of the original benefits were described by Dr. Arthi Huria, where she developed the CARG model. This was a model that was used to predict for chemotherapy-related toxicity, and this was validated in a 500 patient population. This was across cancers, but patients 65 and older, about to start any chemotherapy regimen that their clinician was prescribing them. Patients had baseline geriatric assessment with clinical variables and labs collected, and then toxicities were evaluated at each visit and collected over time with repeat geriatric assessments. And in this study, a high degree of toxicity was seen, with 53% having a grade 3 event, 12% grade 4, and 2% having a grade 5 event. And this allowed her to validate a score system and looking for variables that were most important in making these predictions. And so, in addition to clinical factors like age and cancer type and chemotherapy dosing and blood values, there were really important elements that were drawn out only by that geriatric assessment, including hearing, falls, unable to take medications, being limited in walking, and having decreased social activity. And you can see that each of these things have a weighted score. And in your patient who is about to receive chemotherapy, one can calculate their risk of chemotherapy toxicity, with high risk being the 10 to 19 point range, where that person has an 83% risk of developing a grade 3 or higher event over the course of their chemotherapy. This calculator is widely available and free and is listed in multiple places, including the MyCarg website here for your reference, and can be a really nice tool, especially in the setting of chemotherapy, which I realize isn't the focus of our discussion, but I think is very relevant. This model has also been brought to the early stage breast cancer setting and has been really powerful in what it's been able to do with regard to understanding risk for hospitalization, dose modification, and toxicity in a similar way to that broader population. And in this study, most started with standard doses. This was 65 and older patients who are receiving any adjuvant or neoadjuvant chemotherapy, and again, an early stage setting. And you can see that about a quarter of patients on this study required dose modification, delays, discontinued therapy, received a lower relative dose intensity, or were hospitalized. And in this score model, a lot of similar factors that you saw in the other model became important, but from that geriatric assessment, again, falls, this time being limited in being able to walk greater than a mile, and how often someone is available to you in a crisis are actually incredibly important to predict for toxicity risk. And I think that this can be extrapolated to some degree in other patient populations who aren't getting chemotherapy, just to really understand what that baseline score is can be helpful, and perhaps thinking about how you're going to treat that patient. And even asking limited questions can be helpful. You don't have to always do the full geriatric assessment in a busy practice. You may select a few questions just to try to get at this with the patient in front of you. And again, the CARG BC, which is the breast cancer validation, really showed that the scores are also associated with toxicity, hospitalization, dose reduction and delays, early treatment discontinuation, and relative dose intensity. And now, a practical geriatric assessment has been recommended by ASCO as a standard practice for all patients 65 and older with cancer, regardless of stage and regardless of cancer type. And they have this practical geriatric assessment in that publication, which is available for downloading, and you can look at it. It is a modified version of the original geriatric assessment developed by Dr. Huria, and can be a really nice addition to your practice if you can use it. But there are other shorter assessments. We realize that battery in the geriatric assessment can take about 25 minutes, and sometimes we don't have that time. And so the G8 is something you heard about earlier, which has been incorporated in other studies. This is also a screening tool to give a sense of functional age and risk for frailty. There's also the VES 13, or the Vulnerable Elder Survey. There's also just clinical frailty scales, which you can look at pictures and try to assign where your patient may live. And really, all of these are able to give us an assessment of functional age, and they don't have to be long. I think just thinking about this in your practice can be really helpful to really get a sense of that person's health status. There's also the e-prognosis calculator, which is also free and available on their site, where you can calculate a person's life expectancy outside of their breast cancer, which is based on their comorbidity, function, and behaviors. And so in that person where you're trying to really understand their competing risk of comorbidity and what may threaten their life over time and in what time frame, this can be helpful to help frame discussions as well. And that geriatric assessment, as I mentioned, can help you connect the patient to the resources that they need when it comes to social supports and their function, their mental health, their resource needs, physical health, and increasingly importantly, what matters most, which is something that has been encouraged to be asked of patients in this age group. And in promoting age friendly care, the age friendly health system movement is really pushing having evidence based care of elders aligned with the patient's wishes, goals, and priorities with this 4M's framework as a set with what matters most to the person, their mobility, their mentation, and their medications. This has been sponsored by IHI and is now increasingly entering the oncology community as a focus of how we approach care. And there have been a lot of discussions about the geriatric assessment and a lot of pushback in order to really figure out whether this could actually be put into practice. And this is actually a publication that's now several years old, but I think it highlights, how important this is and how it may compare to other tests that we do that may have similar value or even lower value. And in order to get the geriatric assessment done, it really requires very little time, staff time, and I think it pales in comparison to the costs that we spend on other tests that we use regularly in practice without hesitation. And so, with that in mind, I will turn it back over to Dr. Rugo to discuss a case that will help highlight some of these issues that we've talked about today.
Thanks so much, Rachel. I think that this is such an interesting area, and I'm really glad that you've been able to put more focus into it now and actually have prospective trials that are trying to really address the issue and help us understand how to incorporate an assessment that's right for an older patient and ensures the safest and best treatment for them. And of course, we're focused on metastatic disease, and that's our case. But we can also use this, I think, to think about how we assess treatment for early stage disease as well. So it's quite far reaching. So let's talk about this case a patient who, at 66, had presented with a mass in her breast, her left breast, and a core biopsy showed papillary carcinoma in situ with two less than 1 millimeter foci of grade 1 invasive ductal cancer that was strongly hormone receptor positive. She had a left mastectomy with sentinel lymph node biopsy in an outside hospital, and this showed 2.2 centimeters of papillary carcinoma in situ, and she had multiple foci of microinvasive, so less than 1 millimeter grade 1 IDC, and 4 lymph nodes that were negative for carcinoma. It was not recommended that she receive any adjuvant therapy. I think today, and if it was me, I would recommend adjuvant endocrine therapy for this patient. But there is still, I think, quite a bit of controversy about how we treat postmenopausal women who have this microinvasive disease. Just had a big conversation about a patient who had HER2 positive microinvasive disease, a younger patient. But this goes on. And I think if these are really tiny foci, we're really basing our decisions on the burden of disease, so how many foci you really have. Of course, she didn't need radiation because she'd had a mastectomy. Unfortunately, 6 years later, she had a routine chest x ray for screening for tuberculosis because she runs a daycare center. And this showed an abnormal mass. And on chest CT, there was a new over 7 centimeter posterior chest wall mass arising from the ninth posterior rib. And she also had an unchanged lesion in her left hepatic lobe, which was benign. So she had a right rib core biopsy, and this showed metastatic adenocarcinoma, consistent with a breast primary, strongly ERPR positive, HER2 zero, mammoglobin positive. A bone scan showed only the abnormal soft tissue and bone changes in the posterior right chest wall, no other changes. And a CT scan showed this unchanged, almost 7 centimeter right chest wall mass in her benign liver finding. So, when we're thinking about treatment for a patient like this, the considerations for therapy selection traditionally have included extent of disease, and she had a single large lesion, so oligometastatic disease. The receptor status, strongly HR positive, HER2 negative. Was treating in essentially almost the de novo metastatic setting, having had no prior exposure to endocrine therapy. But, it's not de novo. It's had time to sort of shift genetically over the time it sits around and decides to grow back. You also want to be careful about her activity level and what she expects from her quality of life. She's hypertensive on a single medication with good control, but active and running her own daycare center in the city, in our city. So I think, we have additional considerations that we can put into play based on some of the work that Rachel talked about and is putting forth in her prospective trial. Rachel, tell us about your considerations that you would be thinking about for a patient like this.
Sure. So, you talked about the traditional considerations, and I think in this person, you could also include some functional assessment and helping understand what the risk for toxicity is, incorporating that in the treatment discussion, and of course, thinking about all the efficacy that you talked about. So, let's say a geriatric assessment was done, indicating 2 falls in the last year and limitations in walking more than a mile, despite being active and running her own business. These two factors are actually very strongly associated with toxicity risk to chemotherapy by that calculator we talked about, of course, with caveats in the setting of this non chemotherapy setting that's not early stage. But this really does tell us that the patient is at higher risk for grade 3 or more toxicity. And so you want to think about that as you talk with the patient and discuss it and tell them perhaps your concerns, or maybe you're going to lay out a plan for a little bit more monitoring to watch out for that myelosuppression that might be more likely in this person starting on therapy. And after discussion and reviewing her preferences and perhaps what matters most, an attempt at full dose treatment was started with the plan to quickly adapt dosing if needed, taking a quote, I feel strong. It's important for me to try the standard dose, but being well enough to run my business is crucial. So I'm open to lower doses if I need them.
Great. And I think that's really important. You really have to think about how you're treating these older patients, early 70s. So she started letrozole and full dose palbociclib just at the beginning after palbociclib was available, at least to this patient. And had an episode of grade 4 neutropenia with neutrophils less than 500. So she reduced to 100 milligrams, but then continued on that dose and really did not want to decrease her dose. Some mild fatigue, but still able to do most things. But I will say there is some degree of fatigue, which I think we've seen in these older patient analyses, even the pooled analysis by the FDA. And then if I checked her counts always at day 8, she was a little neutropenic, grade 3 neutropenia. So we just have her come in at a 10-day break, and that seems to work well. She hasn't required any additional dose delays or reduction. She had a reduction in the expansol mixed lytic and sclerotic mass at the ninth posterior rib. And the last scan, which was done at age 84 in January of this 2025, this year, there was no evidence of any malignancy. The unchanged, now they say it's eighth rib. That's very hard for them to count. And she has this mild chronic fatigue, but still is running her daycare center. And at almost 11 years now, she remains without any evaluable disease. And this shows you can see her implant here on the right hand side, but in the left hand side, and on the right hand side here, there's this large mass that she presented with. But then by the later time period, this last scan is from October of 2024, you can see that there's the change in her rib, but there's no additional disease shown here. So very exciting to see this now. We heard, just in terms of our discussion about this patient, we heard from Rachel earlier about some of the goals of care for our older patients and how we really need to get the goals of care from our discussion with patients so that we have shared decision making and how we take into account some of the factors that we see in our older patients, which is so important. This is also a great opportunity for educating patients. How do you use the information we've talked about so far, as well as your own experience, bringing that to the patient in terms of an opportunity for education and talk about their age and outcome strategies, Sarah?
So usually what I do is I go through the most common side effects of the medication. And so if I'm saying to them, you know, a lot of patients on this medication, about a third of patients will experience some fatigue, and that fatigue could be affecting your ability, for instance, to run your daycare or to do the active job that you're doing. What is it that would be sort of the threshold for you of too much fatigue? How much time can you have to rest? What are things that you could do to implement to make this more tolerable? Or is that something that would be really, really bothersome to you or worries you a lot, um, even if you won't experience that, what are you worried about? I think some patients, a lot of the times, by the time they've seen me, they've already been told they're going to start this medication or we're hoping to start it, and they will go and read about it and then come back in and say, "I heard this medication causes diarrhea. I don't want to take it." And so I ask them more about what they know about the medication or what they've heard other people experience. What it is that worries them about that. Do they know about things that we can do to help that symptom, like Imodium, or what knowledge do they have? And then based on that, I can sort of help them navigate starting the medication and managing the side effects that might happen.
I think that's great. And I think as over time, of course, being able to confirm a lot of the education you've already brought into play in the beginning makes a big difference. And also the collaboration and support of our nursing staff, as well as our advanced practice providers in terms of supporting our patients makes a big difference. We do, this G8 screening tool, I think, is not in frequent practice. I guess, Rachel, maybe you could give us some steering about or ideas about how we can use this more effectively in our busy clinics where we're really trying to help people understand we're talking about and what the best way to communicate information is to an older patient. In my clinic yesterday, I was saying, went through this whole explanation about something for a patient, and this is my experience with this patient, and at the end she asked me the same thing I just answered. And, I think that we do see this. And so we really want to make sure we're communicating, but we need to have the best practices. And in that discussion, Rachel, maybe you could talk a little bit about how you use the G8 screening tool in practice.
Sure. Yeah. So in our program, we're very lucky because we have dedicated staff to approach patients who are 70 and older in our program and to offer them a full geriatric assessment. And those assessments come with thresholds for referrals, and we have a communication plan back to clinician and back to patient. And we're quite spoiled. And I realize many centers don't have that ability. One thing that we've done though that I think is doable is if in your new patient assessments, most of us have a new patient questionnaire that goes out to patients before they come into the clinic or something that they do when they arrive at the clinic. And you can add just a few questions in there that a patient will answer ahead of your visit, during your visit, however it works in your workflows, and really just get that quick and dirty information from the patient. And you can really limit it. You can't do a full geriatric assessment, but you could do a G8 or you could do the couple elements that may be important in predicting toxicity that you want to draw out. And our program has started to do that as well. We added it into our new patient questionnaire, and now we kind of know who to target when we approach them and who may really benefit from that deeper dive geriatric assessment. But I think people just have to get this into their routines and make it easy because obviously we're all time burdened in clinic. There's so much that we have to think about and do. And so I think trying to engage the patient either ahead of a visit, after a visit, trying to get them to give us this information can be really useful. And I do think it can help not just with the medication discussions and treatment decisions, but what else is going to help this person? Do they need transportation help, right? For all the labs that we need to check on them and check their myelosuppression. Do they need to meet with a social worker? Are they always coming alone? And they don't have that social support. And these assessments help draw out the sort of richer things that we can do for the patient and include in their care beyond just the treatment discussions. And so, this isn't easy, but I think it's important and I think it's becoming a standard of care. And I do think practices now have to think about how they're going to include this in their assessment of their older adults, whether it's new patients, existing patients, longitudinally, because I don't think it's going away. We're all going to be seeing more of these patients as our population ages. And I think it's important to think about how we can best incorporate those tools.
Those are really important points. And it is important to have your clinic all behind you in this and try and figure out a way to maybe screen patients in advance of you seeing them. And that helps a lot because one of the things you brought up was prior falls. And so, it would be great to be able to have that screening tool already there so that you know what's going on with patients. I think sometimes they're afraid to bring it up when they see you as well, which can make a difference. So this has been an amazing discussion with everybody. I think that we've learned a lot about the current real world evidence with the most recent data. We learned about safety, and we've learned, I think, probably almost most importantly in this discussion, how to take all that information and then use it to make the right decisions along with additional screening tools in our older patients. So, uh, any closing comments, Rachel?
No, I think this was a great discussion. I think you brought in all the important elements around efficacy and safety and decision making. I think one other thing that we didn't touch on that I think is nice to be able to share with a patient who you're thinking about a dose modification in is that from what we know, those dose modifications don't necessarily affect the efficacy, right? All the data you showed, especially in the older adults, many of them had dose reductions, right? They had early treatment discontinuation, and you can still see the benefits. And so I often try to reassure patients that we can actually keep them on study or on treatment, better if we manage their side effects as opposed to having to stop the treatment because of a dangerous side effect. And I think it's really just important to have that open communication reassurance that it's the right thing when you really feel it's the safe choice for the patient.
And that's such an important point, Rachel, because I think that the other thing when we're don't have patients on trials is if you do dose reduce, you can always go back up again. And also, if somebody's really exhausted, it's better they bad mouths or something, whatever it is. It's always better to take a few days break. And in fact, delay in starting a dose reduction when needed had no impact on outcome in any phase 3 trial that we've done so far. So it's really seems like a really important thing to do. And I think Sarah, you really showed that that was a important point to keep in mind. Sarah, any closing comments?
I this was a really needed discussion. I think it's was great to see all that data showing the efficacy and the overall survival, and I hope that it convinces everyone to use these CDK4/6 inhibitors with their patients more if they weren't already, and then also just to be keeping a close eye on their older patients to make sure that they're having the least amount of toxicity, but getting that benefit. So.
I think that's great. And I will say that, the using the G8 assessment helps you to understand how to start your treatment because you don't want to start at 75 milligrams, for example, of Palbo or 200 milligrams of Ribo, something like that if you don't need to. So you really want to keep that in mind. You do want to use the optimal dose for each patient. With that, I'll close. And thanks very much for participating in this program and for all of your important information and for the support of PeerView Institute for Medical Education in organizing this important webinar.
Thank you for listening. Remember to download the slides and practice aids and complete the post test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, Living Beyond Breast Cancer. This activity is supported by an educational grant from Pfizer. To access all materials for this activity, visit peerview.com/ZWD860.